All right, section 15, childhood malignancies. Part 1, formulate a differential diagnosis for petechiae and purpura in a school-age child. Anything that affects the bone marrow can cause easy or free bleeding and bruising. And, you know, a lot of those things are that C word and that L word that we don't like to say in pediatrics. Leukemia, there's lots of different types, AML, ALL. It's important to go back and review those. Differentiate normal and abnormal findings on the examination of lymph nodes, liver, and spleen. You're pretty much always going to be able to feel some shoddy little lymph nodes in the neck and in the inguinal region in kiddos. Sometimes you can feel some little ones behind the ears or posterior neck. Sometimes some pretty good ones in the posterior neck, particularly if there's a ringworm or a lesion on the scalp. Anterior neck, if they've got a pharyngitis, a strep throat, or mono can make some huge lymph nodes in the anterior neck. You should not typically feel lymph nodes in the clavicular region or in the axillary region in kids. If you can, you need to look into why they're there. Little tiny pebble-sized nodes in the inguinal region are common and are very normal. The liver in an infant can be palpable at or just slightly below the costal margin in the mid-axillary line. I would say 1 centimeter finger breadth down from the costal margin in the mid-clavicular, not mid-axillary, but mid-clavicular line in the anterior chest is reasonable for the liver. Any more than that, and I would wonder why. In a newborn, you can sometimes feel the spleen if their belly is relaxed. If I can feel it in an older kid, I'm going to go looking for why, whether that be mono or because of a malignancy. Now, if I'm feeling big lymph nodes and I can feel the liver and a spleen, then that's certainly worrisome. Differential diagnosis of an abdominal mass in the pediatric patient and the necessary workup. Wilms tumor and neuroblastoma. Those are certainly two of the more common pediatric tumors that you would find in the abdomen in kids. So make sure you know what those are, where they would be found, what organ system they involve. Other things you could feel in the belly. Constipation, you would feel stool frequently in the left lower quadrant, and know ways that you could differentiate. Workup, we usually start with an ultrasound if we feel something, and it escalates quite rapidly from there if they find something on ultrasound, CT, biopsy, depending on what it is. Know the location and manifestation of primary CNS tumors. In kids, brain tumors are almost always going to be infratentorial. Remember, in grown-ups, they're going to be supratentorial. Those infratentorial tumors are going to be brain stem. Most of those, unfortunately, are going to be inoperable. That's not good. Radiation, gamma knife, those kinds of things can be palliative care. But survival is not good for those infratentorial tumors. The principles of effectively breaking bad news to a patient and to a patient's parents. You have to know your patient, and you have to factor in their age in determining who should be present, whether it should be the patient and the patient's parents. When you have these initial discussions, obviously if it's a very small child, it's often better to have the discussion with the parents initially, and then bring the child into the conversation to an age-appropriate conversation at an appropriate time. If it's an older adolescent, sometimes it's better to have the conversation with everyone up front. It really just depends on the kid and the family, and that varies. The laws also may be different state to state. So leukemia, lymphoma, Wilms, neuroblastoma, your infratentorial CNS tumors are going to all be important tumors to know about. All right, that's it for childhood malignancies.